Hello and welcome to the MIMOSA Matters podcast series. In this series, we will bring you interesting perspectives on the clinical, research and technological perspectives for near-infrared spectroscopy imaging, or NIRS, and introduce you to MIMOSA Diagnostics. I'm your host, Douglas Queen. Today, we are bringing you a MIMOSA Matters Poster Chat, where you can learn from our collaborators about their important research. Thank you for tuning in and joining us on today's podcast. We will be hearing from Dr. Traci Kimball. She's the Chief Medical Officer and founder for the Wish Clinic in the US. She is a board-certified wound management specialist physician with expertise in hyperbaric medicine, vascular medicine, geriatrics, and surgery. Welcome, Traci.
Thank you, Douglas and Mimosa, for having me today.
Let me start our conversation by asking you a few questions about your poster entitled Working in Synergy to Heal, Integrating Multimodal Therapies with Comprehensive Monitoring, such that our listeners can get some insight into your experience with NIRS imaging. Tell our listeners a little bit about your clinical practice and experience.
I am owner and founder of the Wish Clinic in Arvada, Colorado. We are a comprehensive wound care center, tertiary center, referral center in the state of Colorado. We have patients as far as Craig, Colorado, that through telemedicine and also our brick and mortar care receive care from our providers.
Great, thanks. Give our listeners some background into the study featured in your recent poster at the SAWC Spring conference.
We presented a case of a non-healing wound and a patient with multiple comorbidities, specifically diabetes mellitus and rheumatoid arthritis, who had been on modulating medications when she developed lower extremity mixed etiology ulcers. She actually received care in a local outpatient hospital department for several weeks, developed an infection and got admitted to the hospital for surgical excision of her wounds to both of her lower extremities. She ultimately showed up to the Wish Clinic for tertiary care and second opinion with exposed structures, bone and tendon, and of course the soft tissue defects. We actually quickly deployed NIRS imaging to determine the local vascular inflow for the patient and to ensure that she had adequate oxygenation of her wound beds. And those wounds were then imaged accordingly and in sequence inside of a time series, which ultimately came to roughly around 54 weeks of care. The case was very complex because of her constant glycemic control issues and some syncopal episodes that sent her to the hospital, of course, rule out sepsis that put her in post-acute settings. We initiated a CAMPS journey for her fairly early on in her healing. Unfortunately, during that 8 weeks of care or a planned 8 weeks of care with a camp, she got admitted to the hospital and entered in a Part A reimbursement stay. And so we had to, of course, defer any further camp placement at that time. But we did continue some elements of her care journey and her care plan in the subacute setting where she was residing at the time, specifically with regards to ultrasonic hyperoxia water vapor therapy. And that continued. We didn't actually really get her into a formative sequential camp deployment journey until she was discharged from that Part A stay, showed up back to our clinics over weeks 11 through 54 with a continuance of her negative pressure wound vac therapy, which she was also getting at the time, that was initiated by the original hospital outpatient department. And she continued to show progression. Of course, we proved inflow with the imaging. She did see vascular surgery at one point that did an ultrasound and PVRs to determine that she had inflow to both lesions. And then ultimately, with additional local therapy and great standard of care wound care, with CAMPS deployment, we were able to get this patient closed ultimately, and now she's limbs and her limbs have been salvaged. If you can actually see on the poster, we also provided claims data information about the cost of care from our specific clinic. And of course, we illustrated the multimodal therapy approach. MIMOSA images were utilized to actually monitor the progression in a retrospective way. You can see very late in her course, between weeks 26 and 54, that she essentially, well, actually weeks over the last 17 weeks of her care, I should say, the last 17 weeks of her care, she had expeditious epithelialization and healing. And so I was really impressed with at least the fact that we could continue to monitor her perfusion. We could see the feedback, immediate feedback at point of care, that our treatments were working and were responding to, or her body was responding to, those therapies and modalities.
Great, thanks. And how important was the imaging that you used in respect of documenting this protracted care?
So, well, one, the imaging modality increases efficiency in the throughput of the clinical journey with patients in a in a center where right now it's not a ton of volume, but when you're high volume, I would say that the efficiencies of doing an imaging, a trimodal imaging study such as MIMOSA's product, does increase and enhance the throughput of patients, because we're able to get the nurse feedback, we're able to strategize with regards to inflammation or early infection with the thermography, and then we're also able to get real-time planar metric imaging of the wound to show PAR reduction, percent area reduction, which is wonderful, and one swale swoop of a 3-second click. And then, of course, you have that sequential imaging over a time series, so that any kind of retrospective audit on the care provisions can be completed in a snapshot, as it was illustrated on the poster. So we were able to show week 0 all the way to week 54 in, sort of quadrants or quarters of care, the progression and improvement of the wounds. And that makes this is a game changer, and in a practice such as ours that's highly interventional.
Great. And what's the key message of the poster that you would share with your clinical colleagues?
Well, there's a few. One big overreaching key message is that, cost of care right now, when camps are being deployed, are extremely high. In a patient with this kind of complexity, and of course, the post-acute journey illustrates that, continuance of care of the care plan from time 0 to week 54 to the potential of healing and limb salvage on very complex cases such as this one. And then, of course, using modalities in multimodal approach, using negative pressure, VHT, camps, and of course, standard of care, plus wound bed preparation is extremely important for a complex case such as this. This was a patient that had exposed structure at time of presentation, and adequate wound bed prep with negative pressure wound therapy was deployed, and then that led to an enhancement of her granulation tissue formation over structure. And then when we also added in the VHT, the vaporous hyperoxia therapy, we saw ultimately accelerated development of granulation tissue formation, vascular neogenesis, and improved inflow and oxygenation, as depicted by the NIRS infrared imaging device, so that we could continue to justify medical necessity and the deployment utilization of these technologies.
Thank you, Traci.
Thank you, MIMOSA Diagnostics, for having me today.
Thank you, Traci, for giving our listeners an in-depth insight into NIRS imaging, MIMOSA Pro, and its utility in clinical practice. Well, that's our poster chat for today. We hope you gained some new perspectives on NIRS imaging and its utility in wound management. be sure to visit MIMOSA Diagnostics at www.mimosadiagnostics.com. In particular, check out our Learning Plus section, where you will find all of our poster chats. Visit our social media channels, add your comments and learnings. We want to hear from you.